Hello, welcome to Primetime Live with Next Level Prime. This series is meant to let our listeners hear about all things Next Level Prime. I'm your host, Dr. Karen Rakers, Vice President of Next Level Prime, and I am a family medicine physician, and I've been with Next Level for almost 10 years and really thrilled to have been involved with our Next Level Prime program since it launched over 3 years ago. And just as a reminder for our listeners, Prime is an advanced primary care model. We contract with employers, which allows employees and dependents to have access to unlimited healthcare services at Next Level 7 days a week. We have a virtual care platform, and that is combined with a large network of physical locations in Houston, San Antonio, Austin, and Beaumont. And the care provided includes primary care, preventive care, chronic disease management, urgent care, health coaching, emotional wellness counseling. We also have a team of care navigators, nurses to help our patients with their healthcare journey and managing any referrals that might be needed. Additionally, most common labs and routine vaccines are included in the program. I'm also really excited to share that we recently launched a formal weight loss program for our Prime members. So that's exciting. And all of this care is provided at no cost to the patient. So no copays, no deductibles, no surprise bills. We are really trying to break down the barriers to care, including cost and convenient access. Today, I have Dr. Vivian Ho, a healthcare economist and professor at Rice University and Baylor College of Medicine, on the show with me. Her research examines the effects of economic incentives and regulations on the quality and cost of healthcare, and her research is widely published in economics, medical, and health services research journals. So she has a lot of experience to share with us, and the focus of today's discussion is healthcare economics and why rising costs matter. And I'm thrilled to have Dr. Ho here today to talk to us about her take on this matter. So, Dr. Ho, tell us first, I think, a little bit about maybe your background and some of the work that you have done in the healthcare economics space.
Well, thanks, Dr. Rakers, for inviting me here to be a guest. It's a real pleasure. I've been doing health economics for quite a long time. So I've been in many different places, and the locations in a way have determined the things that I worked on. I started my career out at McGill in Montreal, Canada, School of Medicine. So I naturally ended up doing a lot of comparisons of US and Canadian healthcare. After that, I moved to Washington University in St. Louis in their business school. And being a business place, looked at mergers and acquisitions and their impact, mergers and acquisitions of hospitals and their impact on the quality of care. After that, combination of personal and professional reasons, I was at University of Alabama, Birmingham in their School of Public Health, where I got very interested in looking at the volume outcome effect, how providers that do more of a complex operation can have better outcomes. And that work brought me to Rice University, where I am now. I continue doing that work, but I also get pulled into various different things. For example, freestanding emergency departments,
Yep.
and they're spread here in the US, in Texas, particularly.
Interesting. Probably a topic for another day, but I would love to chat with you on a personal level at some point about your thoughts about Canadian versus US healthcare systems. That would be super interesting. So tell me, I guess, a little bit about what your day-to-day work is like now here at, in Texas at Rice and with Baylor College of Medicine.
Oh, every day is different. My primary goal, working at the Baker Institute, our motto is to be a bridge between the world of ideas and the world of action. So I do a lot of research, analyzing large databases, large claims databases from Medicare or private insurance companies to look at the quality of care. I like to let the data tell me the story. But in the meantime, there will be reporters, the media will be calling to ask about particular issues. So you sort of have to drop everything and comment on everything from the Affordable Care Act to what's going on in terms of surprise bills and things like that. But of course, I also make time to teach. I teach undergraduate and PhD health economics as well.
Wow. You've got your hands full, and it's a big topic. So maybe digging a little bit more into the topic specifically for today, I guess let's talk a little bit about, the healthcare cost issue. So, I mean, everybody sees inflation. It's, costs are going up across the board for everything. So, with everything being more expensive, why focus on healthcare costs?
Well, healthcare costs are extremely high in the US. We're now, 2022 is the last full year of data we have. We spent $4.5 trillion on healthcare in this country. That's a little over 17% of gross domestic product, and about $13,000 per capita in expenditures. And I'm sure most people watching with us today did not feel like they got $13,000 worth of healthcare. So the problem, is that what we've got is these rising costs, and those costs get, when healthcare costs become expensive, that translates into higher health insurance premiums to cover those costs.
Mhm.
And that's what leads to people not being able to afford health insurance, which is driving rates of uninsured people, particularly drops, in employer provided health care.
And probably making a lot more people less healthy because they don't have
Absolutely.
access to care.
Right, right. We're
Rest.
hearing lots of stories about patients saying that they forego visits to the doctor, they forego medicines because they can't afford it, and
Right.
of course, substantial number of people ending up in medical debt, which creates financial crises, which just sort of overflow into the rest of a person's life.
Yeah. So, I mean, a lot of people would probably say, well, does it even matter? I mean, don't the employers pay for healthcare coverage for their employees? Why is this an issue?
Well, if you look at the data over the last 20 years and you look at the cumulative increase in premiums, health insurance premiums, the combined total that employers and employees pay has increased 300%. The disturbing thing is that the amount that the employee has to contribute to that coverage is actually also increased by 300%. So the employer is pitching in more, but making the worker pitch in more. At the same
Mhm.
time, the cumulative increase in workers' earnings has only been about 100%. So
Yeah.
everybody sees this, in our paychecks, our pocketbooks, our take home earnings, are not able to cover the increased earnings of this health insurance coverage if we're lucky enough to get it through our employer.
And again, to your point, that means people are probably just opting out of coverage often.
Exactly.
And also you mentioned, and I mentioned early, like inflation across the board is up. So everything else costs more. And if they are only making 100% more and their healthcare costs went up 300%. So then they don't actually have money to buy all the other things that they need that are also more expensive. It's a big
Right.
problem.
The percent of uninsured in the United States has declined
Okay.
overall. It's about 8% of Americans are uninsured. However, in Texas, we're still well into the double digits. We did not take the Medicaid expansion. So there
Okay.
are a number of low income workers. These are workers, it's not because they're not working. They don't make enough money to qualify for Obamacare, and they can't afford employer provided health insurance. So they are uninsured. It's a big
Got
problem
it.
here in Texas.
Got it. So, why do you think healthcare costs in particular are going up so quickly?
Well, when I teach my students, I like to focus on three particular things that drive healthcare costs up. The first thing is, in general, we have very generous employer provided health insurance coverage despite the cost. But what happens is, once a patient pays a copay or meets their out of pocket maximum, they it doesn't matter to them what the cost is of a very expensive, for example, inpatient stay for, bypass surgery or very expensive things. So they're insensitive to those very high costs because of the way we structure our health insurance. The second thing is, by and large, we reward providers for higher quantity,
Mhm.
not higher quality of care. So any doctor or hospital gets paid more for providing more operations, more diagnostic tests, things like that, but there's no reward for keeping you healthy
Yep.
and keeping you out of the hospital. So you'll say, look, those two things have been going on for a long time. What's the problem now? The third problem is we've had massive consolidation in the healthcare industry,
Mhm.
massive consolidation of hospitals and hospitals acquiring physician groups. And that has led these providers to have tremendous negotiating power when they're negotiating with health insurers. It's given them an advantage, and they are taking advantage of it. And there's been substantial increases in hospital prices. I can tell you, for example, we're working on a paper now. If you look from 2006 to 2023, increase in hospital prices has been about 190%, whereas increases in physician services and in health insurance prices is about 130 to 140%.
Yeah, you just put so many there's so much to, like, possibly dig into with all those things, but basically, point being, the last point is that these big groups now have so much negotiating power, they're driving prices up because they're charging the insurance carriers more.
Absolutely, because when you
Yes.
get a premier healthcare system,
Yep.
the large employers are going to say, look, we have to have that system in our network, otherwise our best employees are going to cut and run. And
Yep.
so they feel over a barrel.
And then your point about rewarding for more care, not quality care, not preventive care, I feel that really, personally as a family medicine physician, completely, agree with that. Um, and that's a big problem. Seeing people more times doesn't necessarily mean should be getting paid more, in all instances. So I guess with all of that, what do you think can be done to just kind of curb or rein in all of these costs? How can we fix it?
Oh, gee, um, could probably, we could spend all day. There's probably 20 or 30 different things. Let me tell you the one that I'm most interested in working on in the next few years, that I'm most excited about. Um, you know, we we have to teach employers, purchasers to be more price sensitive while getting high quality care for their workers. And one way we can do that is something called tiered provider networks. There's been a very exciting paper that came out just last year by a young professor at University of Rochester who looked at a tiered approach in Massachusetts, where they just took hospitals, they looked at their prices, they looked at their quality, and they put them in three different tiers and told the workers, okay, if you go to tier one, you're only going to pay a copay of $250. If you go to tier three, your copay could be, say, $1,000. Very simple. After 3 years, they showed that once they switched to that system, they dropped hospital expenditures by 8.5%. So that's a substantial savings. And the reason why it works is because it's so simple. Lots of other papers by economists did things like, oh, we just gave people a price shopping tool and no one used it, so it didn't work. So the important thing is to get price sensitivity, make it simple, and still guarantee that your workers get access to high quality care.
I like that. That's great. So let's talk a little bit about what we're doing here at Next Level. What role do you think an advanced primary care type model has in maybe controlling some of these costs?
I think advanced primary care is extremely promising because it goes back to what I was saying about, let's not reward for quantity of services, let's reward for the quality of the services. So the provider, and in this case, Next Level, and all of the other physician groups pursuing this model, they're only going to continue to get patients as long as the patients are happy and they are being kept healthy. Um, and there's not this focus on large amounts of administrative billing, making sure the patient comes back as many times as possible so that you can collect more revenue. The focus is on the quality of the care. So that makes the patient happier. It also makes the physician happier because we've got a tremendous problem with burnout. The other thing that I am really excited about is that Next Level and many of the advanced primary care organizations are not vertically integrated. They are independent. And I'm guessing, hope to do research on this, I'm guessing one of the major savings is that patients are not being referred to high cost providers. I'll give an example. Someone at Rice, hate to name names. So someone at Rice said, "Wow, we should add One Medical onto our network."
Yep.
But if you go looking through and you look who One Medical refers their patients to if they need specialty care, it is one of the most expensive healthcare systems in the Houston area. So why would you want that to happen? It's, to me, it's kind of horrifying. And as far as I know, they're not in our network, and I'm relieved.
Yeah. Very interesting. Yeah, that's something for sure on the Next Level side that we've been very careful about, and just, keeping track of referrals and where we're sending people, and trying to use lower cost, high quality specialists outside of us when we can't care for something or need a specialty to be involved in care. So yeah, I can't stress that enough either. It's super important. Big hospital facility fees and things like that are big also in reining in those costs for sure. What other key areas do you think, could maybe be addressed to help control cost? Any other big ones that are top of mind for you?
Well, actually, what you just mentioned about facility fees, so I don't know how many of your viewers realize this, but um, uh, there's something called that is being discussed in Congress now, moving to site neutral payment. Currently, many hospitals want to acquire a physician group because once they own that physician group can bill to an insurer as if it is part of a hospital, even though,
Yeah.
the doctor's office is still the same, the patient's going to the same place, but they can charge their physician fee and a facility fee, which is often over $1,000.
Yeah.
Okay, so that's been one of the big reasons why costs have been rising, and it's one of the big drivers in consolidation. That's extremely important. Also, we've got the FTC and Department of Justice trying to fight consolidation in the healthcare industry.
Okay.
It can be they've been successful recently at just starting to scrutinize potential proposed mergers, and those mergers have the providers have sort of backed off on them. But sometimes it's really hard because you can have one organization that goes off and acquires, say, 20 or 30 little practices all at once, and so that's this slow drip drip drip, and then before you know it, you've got a consolidated market, and that's harder to actually deal with.
Interesting. I mean, so many things play into this. It's just fascinating. And I think things I don't understand as a healthcare provider, and certainly, people patients out in the community don't probably understand at all. But tell me, I guess, a little bit about who funds your research. Who's trying to help figure out what to do here?
So I've been very fortunate. So with this work, it's extremely data intensive, and
Yeah.
so you need funds to actually purchase the data. But even more expensive than that are the programmers
Mhm.
who have the expertise to analyze extremely large databases. So we are very dependent on external resources. I've been very fortunate to receive money from the National Institute of Health in various different grants, also from the Agency for Healthcare Research and Quality. But one organization that has really stepped up recently is Arnold Ventures. So the Arnold Foundation funds that. Arnold Ventures is very interested in improving the quality of healthcare, lowering costs and also and actually improving equity in healthcare. So they have different programs, and one of them is funding some of the work I'm doing. They're funding my work with the National Academy of State Health Policy. They have a hospital cost tool that breaks down financials for hospitals, and we've helped them build that data set. It's longitudinal. We're using that. We've shown that hospitals have increased their profits over the last several years, and those profits have not gone into increased charity care, and instead they've gone into building cash reserves of different hospitals. We're going to look at how those profits are related to CEO pay. How much is there a link between does a CEO of a nonprofit hospital get rewarded for earning higher profits? We're also going to see how tight of a relationship there is between hospital profits and prices, because there's been a lot of complaints, and I'm sure this is true for many hospitals, that COVID has raised their costs, which may be true. And so if prices are rising because costs are higher, then you want to say, well, that's justified. However, if prices are rising because profits are rising, then we all want to take a second look, right?
Lots of big groups definitely interested in trying to help figure this out. I think that's great. And certainly lots of concerns and things to look at, and maybe try to fix those things that you're discussing. I think it's very exciting. You have recently been elected to the National Academy of Medicine. Why don't you tell us a little bit about that and why it's important for these issues, of healthcare cost to be discussed kind of at a national policy level?
Yeah. Oh, yeah. Thanks. It's quite an honor. I got elected to the National Academy of Medicine in 2020. And National Academy of Medicine was created at first to be an advisory wing for Congress regarding any issues related to delivery of healthcare. It started out as the Institute of Medicine, and then was renamed to be a National Academy, along with the National Academy of Science, National Academy of Engineering. So I'm fortunate to be part of a group that has many Nobel Prize winners in medicine. Also, some of the most influential people in healthcare in terms of academics, but also people in industry. Fei Li, who's doing artificial intelligence at Stanford, for example. Really remarkable people. So the National Academy cares deeply about policy that determines what happens in terms of delivery of healthcare. So they can act as the big picture guide for philanthropists and for members of Congress in terms of where we should go, what should we focus on. One of their most important reports was To Err is Human. It was one of the first national reports talking about medical errors, how common they were in healthcare, and what could be done about them. And that sort of generated, the last 2 decades worth of work in terms of healthcare quality. But they are also working, they care very deeply about disparities. They care deeply about new technologies. We've got some very successful, genetic medicine, those types of things, which are very expensive, drug care costs, climate change, you name it, they're involved in it. So it's a very exciting organization. I'm fortunate to be a part of it.
That sounds so awesome. I'm thrilled that you are able to be a part of that.
As a matter of fact, I'm talking with them tomorrow because they want to have a session on the impact of consolidation and private equity on the quality of healthcare. So I'm actually going to be speaking with them on that issue.
All super important issues. Well, Dr. Ho, thank you so much for taking the time to join me today. Great discussion. And thank you for doing this super important work, bringing these issues to light, helping to find solutions. Hopefully we will get there one day and have a better system. And thank you all to our listeners out there. We're going to wrap it up today. Thank you. And we'll see you next time on Primetime Live.